Hi, good morning, my friends. It's me, Dr. Mohammed Kazafi. Actually, I wanted to present this case from very long time, and I find today that this is a good time that I can present this case. It's me, Dr. Mohammed Kazafi. You are watching Dr. Mohammed Kazafi Views, where there is a morning, there is a good morning, and where there is the evening, there is a good evening for everybody and everyone. My topic is a very, very important topic, and nowadays it's very common. Indeed, that's the topic is vertebral augmentation, and where, how, and when we can choose the vertebral augmentation. I want to present in front of you people. Thank you so much for appreciating me. Please share, like, and subscribe me. Vertebral augmentation is an kyphoplasty and the vertebroplasty are the most common form of the vertebral augmentation that can be defined as the injection of the bone cement, often under fluoroscopy, into the fractured vertebra percutaneously. The primary purpose of this procedure is the improvement of acute pain and patient's function. Furthermore, they can prevent the recurrence of the vertebral pain in the long term as well. So the purpose of this lecture is, so by the help of the vertebral augmentation, how we can treat the pain or treat the vertebral pain. Vertebroplasty has been the focus of the majority of the systemic review for vertebral augmentation rather than the kyphoplasty. The results of meta-analysis regarding the efficacy of the vertebral augmentation procedure to reduce pain have been largely inconclusive. The mixed results and inconclusive evidence can often be contributed to study design or the quality of the studies performed. Interestingly, when compared to the conservative management, vertebral augmentation has been shown to be favorable with improved pain as well as disability in patients. When compared to a placebo-controlled trial or a sham vertebral augmentation, the results do not show clinically significant benefit for vertebral augmentation in osteoporotic compression fracture of the spine. I want to repeat this sentence. When compared to the placebo-controlled trial or sham vertebral augmentation, the results do not show a clinical significant benefit for the vertebral augmentation in osteoporotic compression fracture of the spine. So, complicating the evidence is how multiple studies have shown mortality benefit for patients undergoing vertebral augmentation for refractory pain secondary to osteoporotic compression fracture of the spine when compared to the conservative management. So, the separate similar studies have not found a significant difference in mortality between the patient undergoing vertebroplasty compared to those undergoing conservative management when accounting for the selection bias. The studies have showed no benefit to vertebral augmentation, did not continue observing patient for the longer period of a year or more than 1 year. Here, there have been multiple conflicting controlled trials regarding patients with osteoporotic compression fracture of the spine, optimizing of the vertebroplasty. These separate controlled trials showed no significant reduction in pain for vertebral augmentation when compared to the control. There was also shown to be no decrease in the use of the oral pain medication or improvement in reported quality of the life and the reported disability. In comparison, one sham controlled trial did show a significant decrease in reported pain for patient undergoing vertebral augmentation. Additionally, this study showed improvement in reported pain score as well as a decrease in the disability score. So research reports these scores at 1, 3, and 6 month duration following treatment. There have been concern for the discrepancies in study design across various studies. Some of these concerns include the duration of the back pain before vertebroplasty and lack of confirmation of bone marrow. Edema is the location of an osteoporotic compression fracture prior to augmentation. Also, vertebral augmentation is not being completed during the acute or subacute phase following a compression fracture. Acute would be considered pain for less than 1 month in duration, and subacute consider pain for less than 3 months in duration. Symptoms for less than a 3-month duration are considered to be the most beneficial time for the patient to undergo augmentation. Potential alternative for the patient who have contraindication for the vertebral augmentation are median branch radiofrequency ablation or facet joint injection for attempted pain relief. Bracing would also be the potential option for the acute or subacute phase of pain after an osteoporotic compression fracture to aid in pain control. However, bracing can lead to atrophy of the core musculature with prolonged use. Bracing has also been shown to have limited efficacy with long-term use. Spinal fusion surgery can loosely be described as fusing 2 or more of the patient's vertebral body together. Studies have shown the patient undergoing surgery have decreased level of pain in both short and intermediate follow-up after surgery. However, there are limited disability outcome for patient during vertebral fusion. So there has been a recommendation for patients with low back pain greater than 1 year in duration with pain non-radicular in nature to undergo spinal fusion. Some experts consider spinal fusion to be the reasonable treatment option for refractory osteoporotic compression fracture despite having inadequate evidence of its effectiveness in the long term. Anatomy and the physiology I want to discuss a bit here because the 33 vertebra comprises the human spine. Each vertebra is organized one on the top of the other. The lumbar spine, made up of 5 vertebrae, is the most common site of the compression fracture that requires vertebral augmentation, which between each vertebra is the intervertebral disc, which act as a shock absorber and keep bone from the contracting each other. The posterior aspect of the vertebra contain a spinous process that is palpable on a physical exam. Lateral to the spinous process are 2 transfer processes which connect to the spinous process via lamina. Pedicle connect the vertebral body to the transfer process anteriorly. Together, the pedicle, lamina, spinous, and the transfer process make up the vertebral arch. The pedicle connect the vertebral body to the transfer process anteriorly. So together the pedicle, lamina, spinous, and the transfer process make up the vertebral arch, and the spinal canal runs within the hollow space created by the vertebral body anteriorly, and transfer process laterally, and the lamina and the spinous process posteriorly, and the spinal cord resides within the spinal canal, as well as good blood vessels, flats, fat, and the ligaments. The spinal cord runs from the brain stem to the first lumbar vertebra. It is roughly 2.5 centimeter thick, inferior to the L1, we can say lumbar 1. The spinal cord nerve separate into the theria equina. There are 31 spinal nerves that branch off the spinal canal. The spinal nerve exits the spinal canal under the pedicle at the intervertebral foramen. These spinal nerves are organized and numbered according to the vertebra which exist in the spinal canal. Above this separate spinal nerve, these are 8 cervical spinal nerves numbered C1, C2, C3, C4, C5, C6, C7, and C8. Likewise, the 12 thoracic spinal nerve numbered T1, T2, T3, T4, T5, T6, T7, T8, T9, T10, T11, and T12. 5 lumbar spinal nerve at L1, which from L1 to L5, which are pronounced like the L1, L2, L3, L4, L5, and the 5 sacral spinal nerve numbered from S1 to S5 like S1, S2, S3, S4, S5. And there is also one coccygeal nerve. Same way, each vertebra has 4 facet joints. Each vertebra has 4 facet joints. I repeat, each vertebra has 4 facet joints. 2 superior facet joints and 2 inferior facet joints connect each vertebra. For example, the superior facet of the L2 connect the inferior facet of L1 superiorly, and the inferior facet of the L2 connect the superior facet of L3 inferiorly. So the paravertebral muscle runs longitudinally along the spine, and there are 3 main ligaments of the spine: the ligamentum flavum, the anterior ligament longitudinal ligament, and the posterior longitudinal ligament. The posterior longitudinal ligament and the anterior longitudinal ligament are continuous band-like structure that run along the spinal column of the vertebral body. The anterior longitudinal ligament and posterior longitudinal ligament prevent excessive motion of the vertebra, and separately the ligamentum flavum attached between the lamina of each vertebra. The basis of proceeding with vertebral augmentation, despite having limited evidence when compared to the placebo in patients with the osteoporotic compression fracture, is the lack of generalized conclusion for various trials and expert opinion. Despite multiple studies, there is insufficient information to conclusively determine if there are specific patient subpopulation that would or would not benefit from the vertebral augmentation. If a patient's pain secondary to an osteoporotic compression fracture is unable to be weaned off from the opioid analgesic because of its persistent nature, or if a patient has developed significant side effect to opioid analgesics, some experts' opinion suggests the vertebral augmentation as a possible treatment option for osteoporotic compression fracture. Significant side effects from opioid analgesic would include constipation, respiratory depression, confusion, nausea, and urinary retention. So the basis of proceeding with the vertebral augmentation, despite having limited evidence as compared to the placebo in patients with the osteoporotic compression fracture, is the lack of generalized conclusion for various trial and expert opinion. So one study compared patient demographic for those with the persistent and severe back pain considering undergoing vertebral augmentation, and there were 2 groups in each study, and group either underwent kyphoplasty or opted for the conservative management. The patient included in the study had pain for the greater than the 3 week duration, and patients who respond to the conservative management did not undergo vertebral augmentation. The augmentation group include patients who failed conservative management, and the kyphoplasty serve as an alternative therapy, and the conservative management patient had better pain score at 1 year follow-up being compared to the vertebral augmentation group. So the augmentation group was found to be more obese with more severe osteoporosis and with a T score of less than 2.8. The augmentation group was found to be older and with the greater compression of the vertebral body when compared to the conservative treatment group. Patients who opted for the kyphoplasty had significantly greater risk factor compared to the patient who responded to the conservative therapy. Multiple studies have been focusing on the patients suffering from the multiple myeloma with metastatic pathological compression fracture. In this select group of the patient, kyphoplasty have been found to significantly decrease the need of the patient requirement of walking aid post-vertebral augmentation, as well as the need for the oral pain medication. In one study done in patients with the pathological compression fracture, kyphoplasty led to be decrease in the necessity for the bed rest secondary to the pain compared to the conservative management. In a separate uncontrolled study, kyphoplasty was shown to significantly decrease patient-reported pain and an improvement in their underlying physical and social functioning, as well as patient-reported vitality. Over 80% of the patients who underwent kyphoplasty reported pain relief in this study. In addition, the 57 patients with the pathological fracture secondary to the malignancy, there were either a complete or significant resolution of pain in 84% of patients who underwent kyphoplasty or vertebroplasty. The mean score remained insignificant decrease at 1 year following the procedure. Over half of the systemic review focused on the vertebral augmentation for patients with the underlying cancer. There was a significant improvement in pain scoring following the procedure. The research showed similar score for the reported need for the pharmacological analgesia and inpatient disability. Another indication for the vertebral augmentation would include the vertebral angioma. There is no neurological symptom and the intractable pain. The contraindication in the selection criteria for patient undergoing vertebral augmentation would not include patient in the mild or moderate pain secondary to the vertebral fracture. Conservative and the pharmacological management should be first-line treatment. Patient with an osteoporotic compression fracture should initially receive medical management, and the incidence has not been shown vertebral augmentation to be more beneficial than a placebo in this population. The vertebral augmentation is not indicated in mild or moderate pain of the osteoporotic compression fracture. The American Society of the Bone and the Mineral Research advise against the use of the osteoplasty or vertebroplasty in acute osteoporotic compression fracture. So, the American Society of Bone and the Minerals Research advise against the use of the kyphoplasty or vertebroplasty in the acute osteoporotic compression fracture. I think it's a statement. And the patient with the osteoporotic compression fracture should initially receive medical treatment. The evidence has not shown the vertebral augmentation to be more beneficial than the placebo in the population. So the vertebral augmentation is not indicated in mild or moderate pain of the osteoporotic compression fracture. When a vertebral fracture is severe, patient facet joint has suffered compromise, it may contraindicate vertebral augmentation. A relative contraindication of vertebral augmentation is the vertebral body fracture with posterior cortical breach. The concern for the osteokyphoplasty in patients with the posterior cortical branch arise when balloon inflation stops with the pressure that was above 250 psi, and the balloon then contacts the cortical surface of the vertebral body, and posteriorly this could lead to the extravasation of the cement and the neurological damage. The complete vertebral body collapse would be a true contraindication to vertebral augmentation. An underlying fracture of the posterior wall of the vertebra has potentially serious complication, and this would include the extravasation of the extravasation of the cement and leading to the catastrophic neurological damage. So it is a relative contraindication, but the absolute contraindication for complete vertebral collapse, but the relative contraindication for the vertebral augmentation in the vertebral body fracture with the posterior cortical breach, and it can cause the extravasation of the cement. So use of the balloon is important here and with the care. Other absolute contraindication include the unstable fracture, active infection of the spine, or the injection site and the coagulation disorder. Equipment we need here, for example, for augmentation, local anesthesia, we need the fluoroscope, we need the trocar, large hollow tube. For kyphoplasty, a balloon, temp, and the catheter are needed to inflate the vertebral body. Peripheral intravenous cannulae with intravenous fluids, a vital sign monitoring device, orthopedic bone cement delivery device. The physician performing the procedure often specialize in interventional radiology, interventional pain or neurosurgery. Nurse technologist and the operator of the fluoroscope X-ray technician for medical assistant. The preparation for the procedure often take place in an outpatient setting, and they can be performed with or without sedation or general anesthesia. The clinician usually order lab before the procedure. The kidney function is frequently evaluated and is necessary when using contrast. Patients with reduced kidney function are at increased risk of contrast-induced nephropathy. Basic metabolic panel with estimated glomerular filtration rate, for example GFR, estimated GFR, and basic metabolic panel we have to need it to assess before surgery. Coagulation factor are also often ordered before the procedure to evaluate for the blood clotting. Prothrombin time, international normalization ratio, complete blood count, and the clinician would also have ordered and received X-rays and the magnetic resonance imaging of the spine before the procedure. Technique of treatment, the difference between the kyphoplasty and the vertebroplasty is as follows. The kyphoplasty, there is an inflatable balloon inserted into the fracture of the vertebral body, and this balloon creates a low pressure space for the injection of the bone cement, and this process helps reduce underlying vertebral fracture. In comparison, vertebroplasty is the injection of the bony cement without inflatable balloon placement directing into the vertebral body. When compared, vertebroplasty and the kyphoplasty have different criteria for patient to undergo augmentation. Vertebroplasty is indicated if an MRI shows bone marrow edema in case of the suspected back pain, secondary to an osteoporotic compression fracture. Bone marrow edema is typical consistent with an underlying fracture of the vertebra. Therefore, in vertebroplasty, there is only need to minimal underlying compression of the vertebral body to undergo the procedure. The kyphoplasty is a technique that requires a bilateral percutaneous balloon temp insert into the vertebral body, and giving the kyphoplasty is a more technically challenging procedure. It is also more expensive when compared to the vertebroplasty. Kyphoplasty is also performed much more frequently than vertebroplasty when comparing outcome of the kyphoplasty to vertebroplasty. There are limited results, but the evidence for both long and short-term pain disability score is largely inconclusive in comparison studies. When comparing kyphoplasty to vertebroplasty, multiple observational studies of the patient with osteoporotic vertebral compression fracture have shown kyphoplasty improving patient and pain as well as decreasing disability. The results have been less conclusive for vertebroplasty, although encouraging. There have been no sham control trial done for kyphoplasty, and there are only limited randomized control trial on kyphoplasty. The large randomized control trial compared kyphoplasty to neurosurgical care include pharmaceutical management, and the result of this trial showed a statistically significant improvement for both pain and quality of life scores after 1 month of the therapy. This improvement failed to be significant after 12 to 24 months of observation. The pain scores were measured at 12 months following treatment, but no 3 or 6 months following the intervention. The study flaw was the failure to capture pain and the quality of the life score during bone healing of an osteoporotic compression fracture in the acute and subacute period following the fracture. So the complications, like every procedure, in this procedure also, the predominant side effect on reaction associated with the both kyphoplasty and the vertebroplasty is extravasation of the injected cement, which potentially lead to the increased pain or damage to the underlying nerve root, and reported have demonstrated the cement embolization to the pulmonary vasculature can occur following procedure. However, research has yet to document any adverse reaction regardless of the radiological evidence of the embolization. Recent studies have shown the vertebral cement to be associated with bone necrosis, and the infection is an infrequent complication from both kyphoplasty and the vertebroplasty if it occurs, and it can be serious. And there has also been an associated of the new fracture in many randomized control trials after patient received the vertebroplasty when compared to the control. Clinical significance: there is evidence to show vertebral augmentation can decrease height loss and the severity of the spinal deformity. The American Society of the Radiation Oncology randomized recommend patient with the pathological fracture secondary to the vertebral metastasis who elect to undergo vertebroplasty also proceed with the concurrent radiation therapy. There is a limited side effect profile for the majority of patients undergoing vertebral augmentation. There is a promising evidence of the pain relief in patients with the metastatic multiple myeloma and similar evidence of the malignancy with bone metastasis. Vertebral augmentation should not be considered a first line of treatment option for the patient with the osteoporotic compression fracture of the lumbar spine. Some experts recommend it for the refractory case with persistent and severe pain. There have been limited studies completed on kyphoplasty in comparison to the vertebroplasty. More randomized controlled trials need to complete for the kyphoplasty to determine the efficacy fully. To enhance the healthcare team, the vertebroplasty is a minor procedure and can be associated with few complications, but it is often associated with the limited efficacy expected from the select population. This is imperative to identify the correct demography and perform a thorough assessment of the patient before vertebral augmentation. The team approach is an ideal way to limit an unnecessary procedure. Before vertebroplasty, the patient should have the following done. The failed conservative management: the patient has shown radiographic evidence of pain in the area of the compression fracture. The patient has considered alternative treatment option, a diagnosis of the osteoporotic compression fracture or pathological fracture of the lumbar spine secondary to the multiple myeloma or similar malignancy has occurred. The patient has undergone evaluation of either neurosurgery, pain medicine, or orthopedic surgery, and the advanced imaging such as MRI has been done. Labs to assess for renal function and coagulation disorder have been complete. The procedure required for the effort of the interprofessional healthcare, while care may initiate with the family physician and like that. So, till I will conclude this topic on the indication, the basis of the proceeding with the vertebral augmentation, despite having the limited evidence that when compared to the placebo in patient with osteoporotic compression fracture, is the lack of generalized conclusion for the various trial and expert opinion. Despite multiple studies, there is insufficient information to conclusively determine there is a specific patient subpopulational that would or would not benefit from the vertebral augmentation. But if patient's pain secondary to an osteoporotic compression fracture is unable to wean off from the opioid analgesic because of the persistent nature, or if the patient has developed a significant side effect to opioid malignancy analgesia, some expert opinions suggest the vertebral augmentation as a possible treatment option for the osteoporotic compression fracture. Significant side effect from the analgesia would, such as the constipation, respiratory depression, confusion, nausea, and urinary retention. So one study and a compared patient demographic, there is an indication for vertebral augmentation where we can say there is a for example, there is a pain management by the medicine is failed. So that's all from the today's lecture. I hope I just put some light over it. Maybe you like this lecture. If you like it, please share it, subscribe it. Thank you so much.